Was the countdown helpful? Now, this section is a bit more fun, I think, because actually this is, when I was training not so long ago, I found this really, really difficult. No one ever explained to me how to write up fluids for a patient, how to understand what fluids we write up for a patient. They explained to me compartment models, intracellular, extracellular, interstitial spaces, all of this kind of stuff. But no one actually gave me any real explanation of why we do what we do for patients on the wards. Why is it that when you go to a patient, you see on their drug chart they've got a normal bag of normal saline, they've got a bag of normal dextrose? Why have they got that rather than something else? And then the other thing was electrolytes, particularly sodium. All I ever seem to come across in all the books with hyponatremia, low sodium, is just a long, long list of things. What I'm going to try and do in the next half an hour, 45 minutes, is put all of that together for you into a system whereby you actually understand what you're talking about when it comes to fluids and when it comes to basic electrolyte aberrations. Particularly, I want to talk about sodium, potassium, and calcium, because those are the most important ones clinically. So let's start with this very basic physiology, the Vitruvian man who weighs 70 kilograms in weight, 60% water, which is roughly 42 litres. That is the background, but largely irrelevant. Just to say, not everyone's the same, depending on your sex, depending on your density or body fat, the amount of water will vary, but that's okay as a general rule. This is important. This is the compartment model. This is how we break up the different compartments in the body, and this is important clinically. Basically, we have the extracellular fluid, so all of the stuff outside of the cells, and the intracellular fluid, all the stuff inside the cells. And roughly 2/3 of our water is inside and 1/3 is outside. When it comes to that stuff outside, there are 3 other compartments. The interstitial fluid, so if you just imagine a sort of histological image with a vessel running through it and some cells, the space around those cells, but outside the blood vessel, is the interstitial fluid. And then the stuff in the vessel is what we call plasma, which is the fluid in the blood. And then finally, we have this weird small group of transcellular. This is things like optic fluid, cerebrospinal fluid, pleural fluid, fluid around the heart, etc. Not so important clinically. Okay, and then there's just a very simple rule, 60-40-20, 60% water as a whole, 40% of that intracellular, 20% intracellular. Easy peasy. Okay, now when we think about electrolytes, going back to basic chemistry, you've either got positive ones, negative ones. Positives are your cations, negative are your anions. Now, depending on whether we're talking ICF, intracellular, or ECF, extracellular, different ones are important. So intracellularly, potassium is the most important. And I want you to actually, from today, I want you to remember these ranges. There are very few ranges you need to know in medicine, but these are ones that it is worth learning early. Potassium is maintained between 3.5 and 5. Sodium between 135 and 145. And sodium is your major extracellular cation. When it comes to anions, the intracellular anions are mainly the proteins and phosphate. They're those large negative molecules found in cells. And then extracellular, mainly the chloride and the bicarbonate. And bicarbonate is another one you should try and remember, 22 to 26. And what determines how these fluids are distributed? Everybody talks about diffusion, osmosis, osmotic gradients, transfusion gradients, all this kind of stuff. What actually is important? Well, when we look at the balance between the intracellular and the extracellular, it's the osmotic forces that are important. It's this concept of osmolality, which I'll speak about in a second. When we look at the distribution between the interstitium and the plasma, so those two major components of the extracellular fluid compartment, we talk about Starling's forces, which are one of those physiology things that some of you will be covering now, some of you would have covered them last year. but they're very important for the balance there. So when we're talking about intracellular, extracellular, the important thing is this concept of osmolality, the total number of solute particles in a solvent per millimeter cubed of water when it's at room pressure, whatever. Okay, but the main thing is there's this concept, and it has to be the same. And if it's not the same, biology does everything it can to make it the same. So that's when you get fluids and stuff moving. Okay, so if solutes are added to either side, then fluid moves to restore osmolality, provided the solutes are not freely distributed. Okay. What makes up osmolality? You will see osmolality quoted. Sometimes you're expected to calculate it when you're seeing a patient for good reason, because sometimes there can be substances causing a rise in osmolality in the extracellular fluid that we want to know about. We want to know if the osmolality is not normal because it's going to start sucking all of this fluid from the intracellular compartment. So how do we calculate it? Well, we take all the important charged molecules. So that's, if you remember, sodium from the interstitial, potassium intercellular, chloride bicarbonate, again from the extracellular fluid, particularly plasma, and we take the important uncharged molecules in the blood, which are urea and glucose. And we add them all up. Because cations must equal anions, i.e. because these have to be an equal number to these, because those two are positive, those two are negative, actually what we can do is we can twice the sodium and the potassium, add the urea, add the glucose, and we should get that. That's a normal osmolality. And you can already see a situation where the osmolality may not be normal. Say, for example, someone had, as we spoke about earlier, type 1 diabetes, type 2 diabetes. They have a massively raised glucose. If you remember when I gave the example of type 2 diabetes and their sticky blood, when they get that honk syndrome, their osmolality was up at 360. Okay? And that's quite abnormal, as you can see here. The other situation is if perhaps if someone has renal failure, or acute dehydration causing renal failure, and their urea goes very, very high. That will also alter the osmolality and will alter the forces and distribution of fluids across the different membranes. Okay, so here we go. Examples: elevated sodium, elevated glucose. So osmolality, osmotic forces, is what determines intracellular and extracellular fluid distribution. When we talk about the distribution between vessels and the interstitium, this is when we talk about Starling's forces, and this is the thing that's really, really useful clinically, and I'll explain why. But just to recap, at the arteriolar end of a capillary, you get net fluid loss, and at the venular end, you get net fluid reabsorption. And the reason for this is the pressure is higher at the arteriolar end, but the oncotic pressure in the blood is the same, it's a constant, so you get net loss. But at the other end, where the pressure is low and this constant is still the same, you get net reabsorption. Obviously, there's another constant in here, which is permeability, which can be altered, obviously, in a number of disease states, such as inflammation, where the vessel wall becomes leaky and you get more fluid coming out, which is why if you cut your arm, it swells up. Okay, so what we know from this diagram is that the vascular versus interstitial balance, so those are the two important compartments of the extracellular fluid, depend upon the pressure gradient, the oncotic pressure of the blood, and the permeability of the vessel. Okay, I'm going to say that again. The distribution depends upon the pressure gradient, the oncotic pressure, and the permeability. Has everyone heard of transudates and exudates? A few nods, yes. We talk about transudates and exudates in all things. When we talk about ascites, when we talk about pleural effusions, all sorts of stuff. This is how it will start to make sense to you. If you get a disturbance in either the pressure gradient or the oncotic pressure of the blood, you get a transudate. If you get a problem with the vessel itself, such as inflammation, such as something which a mass effect, say, on the vessel that makes it very permeable, you get an exudate. So, anyone know what this is? It's a pleural effusion, yeah. loss of the convexity at the lower end, massive pleural effusion of the left middle, lower lobes, middle and lower zones. What's this? A cat, yeah. It's an acidic cat. The same principles again. It's all about transudates and exudates if you're thinking about causes. So, traditionally, you would have just learned this. You would have gone, oh yes, a transudate is caused by failure, cirrhosis, hypoalbuminemia, whatever. Exudate is caused by malignancy, infection, or inflammation. Now you can begin to see why this is the case. A transudate, i.e. something that is caused by a disturbance in the pressure gradient or the oncotic pressure, is caused by these things. And it's obvious why these things, because cardiac failure, okay, that causes an alteration in pressure gradients, doesn't it? If you think about left ventricular hypertrophy, back pressure, causes a loss of the normal pressure gradients in the pulmonary vasculature, and that causes transudation of fluid outside to where it shouldn't be. Liver cirrhosis. Your liver mainly produces albumin, so that alters the oncotic pressure. Hypoalbuminemia, as I just said. SVC obstruction, superior venal caval obstruction, something that's probably you may not have heard of before, but you'll understand that that could cause a transudation because it alters pressure. Constrictive pericarditis, again, you may not be familiar with that, but you know that it's causing a pressure effect, it's constrictive. These things, on the other hand, make stuff, break stuff, they make stuff leaky. So malignancy, tumours, inflammation, infection, all of these things destroy the normal function of the vessel, making it more permeable. And therefore, these things cause exudates. Now, because in an exudate, you've lost your vessel permeability, stuff can leak out. And what leaks out? Protein does, which is why the protein level in an exudate is high, while in a transudate, it's not high. Okay. That's the simple way of really understanding and relating transudates and exudates to Starling's forces. Okay, so this is just a very simple overview if you want to understand fluids of what we require per day. Okay, we've got inputs, obviously, we've got outputs, and in terms of fluids, the key figure is 3 litres per day, generally. For an adult, 20 to maybe 65 years of age, 30 litres per day. And that's in lots of different forms. So food, water, a little bit of water of oxidation, and loss in urine and stool. Never ever forget, however, these losses here. These are very important. The amount of fluid that's lost from the skin simply through sweating, and actually water that's lost through ventilation as well, comes to about a litre, 0.5 to 1 litre per day. And then, of course, importantly, we need other stuff as well, sodium and potassium as electrolytes. And this is actually what if you want to figure it out exactly, you don't like 3 litres, it comes to roughly 40 mils per kilogram per day. In terms of electrolytes, these are the figures you must remember. So remember, sodium, normal range, 135 to 145, but we require 100 millimoles per day. Potassium, normal range 3.5 to 5, and we require 60 per day. Okay, so how do we keep all of these things in regulation? What systems are there that keep our fluids and our salts in a homeostatic state of being? What I want to do is consider it from two different levels to show you the 2 different important systems. In the first situation, we'll look at the situation where there's water deficit and water excess, and then we'll look at salt deficit and salt excess. And the key players in all of this are the extra-renal system, which are mainly the osmo and baroreceptors, and the intra-renal system, which is this horrendous renin, angiotensin, aldosterone system, which I'm sure you're all very familiar with. So, the extra-renal system is the one we really think about when we're talking about water. From now on, when you think just water, pure water, water deficit, pure water excess, extra-renal system is the one that's important, mainly to do with osmoreceptors, and this is where the posterior pituitary and ADH starts coming into effect. Antidiuretic hormone. The baroreceptors play some role as well, such as the baroreceptors in the carotids, but the major effect is from osmoreceptors. Okay, so this is what happens. There is a water deficit. Because there's a water deficit, the plasma osmolality goes up. Because of that, vasopressin is ADH is secreted from the posterior pituitary, which leads to water reabsorption. And the reverse happens when there's water excess. The intra-renal system has its action mainly due to a change in volume. It's stimulated by reduced renal perfusion and actions via this system mainly, so the renin, angiotensin, aldosterone system. And it all has to do this side with sodium deficit and sodium excess. That's how it's controlled. And this is a picture which I probably nicked from somewhere, which I shouldn't have done and will get in trouble for, no doubt. But this is the basic system where at the start point you've got your blood pressure, reduced perfusion of the juxtaglomerular apparatus, renin secreted, angiotensin cleaved to angiotensin I, ACE then converts to angiotensin II, mainly in the lungs, and then angiotensin II has a direct effect on blood pressure, but also, and this is where the salt comes in, also through leading to aldosterone, which is mineralocorticoid. Remember, mineralocorticoids, salt retention. So, as I said, lots of things. Aldosterone production, sympathetic activation, vasoconstriction, ADH secretion. And what you'll see at the very end here is the reason why it all gets very confusing. And that's because all of the systems intertwine together. So you can't purely, even though I've said when you think of water, think of extra, when you think of salt, think of intra-renal, you can't purely go on that. And that's for a good reason, because if you had failure of one system, you then get failure of all of them. And that's the essence, really, of good homeostasis, of why we have those mechanisms. Okay, so in summary, extra-renal osmolality via ADH, and then intra-renal renal perfusion via the renin, angiotensin, aldosterone system. Okay, so that's the basics. That's the basic physiology. What goes wrong? Well, just like with hormones, you have too much or you can have too little. Why might you have too much fluid? You could take in too much fluid. That's very rarely a problem. You could have increased or inappropriate sodium reabsorption. Okay, sodium and water, through those two systems, very closely linked. Situations that occurs are in things such as cardiac failure, sometimes in nephrotic syndrome. Reduced excretion, or you can have too much fluid because you're not getting rid of it. There's no way to get it out of the body. And the best example of that is, of course, renal failure. And this is what happens. So when you have too much fluid, this is one of the clinical manifestations. This, first of all, this doesn't look good, does it? It's not normal. The heart is very big. There's these bilateral infiltrates all over the lung. There's all this stuff up here in the upper lobes. And I think there may be a little, yeah, just there. There's fluid in the horizontal fissure, which are the cardinal signs of failure. Pulmonary edema is what this is. One of the clinical manifestations of having too much fluid on board. Clinically, these are the other things that you would look for. A raised jugular venous pressure, indicating that the right side of the heart has started to become involved, and peripheral edema, peripheral pitting edema, indicating inappropriate large amounts of water on board, usually because of salt reabsorption, or excess salt reabsorption. Okay, so that's too much fluid. What about too little fluid? Okay, well, inadequate intake, yeah, absolutely, during illness. A distribution problem. Okay, water could be going into an inappropriate space, and it may be doing that because of disturbance within those mechanisms that we already spoke about. So within the Starling Forces, for example, say the vessels are very, very permeable. You can get large volumes of water going into inappropriate spaces. Does anyone know any examples of that? This gives me a chance to have a sip of coffee, mainly. Anyone? Pancreatitis. So the big one is pancreatitis. Think about it. Pancreas, big bag of enzymes sitting in the middle of the abdomen. It gets inflamed, okay, and it starts leaking. You know, imagine pouring acid into your abdomen. Now that's the sort of effect that you're getting with pancreatitis. So all of the vessels all around the mesentery, everywhere, get very leaky. And what happens is all the fluid then pours out. And that's what this phenomenon of third spacing is. The other example is in bowel obstruction. You also get large amounts of fluid being sequestered within the walls of the bowel and around the bowel in bowel obstruction due to inflammation and due to pressure effects. And finally, and probably most obviously, is excess loss. Why have you not got a lot of water? Well, it's come out of you from some way, and it's not always diarrhea. It's not always polyuria, say in diabetes. Remember these two, okay? Anyone with a fever, whether it's a 90-year-old or you and me, will be losing lots and lots of fluid through the skin simply through sweating. Remember, respiration. Someone who is breathing very fast, breathing greater than 20 respirations per minute, will be losing a lot of fluid from the lungs. And blood, fairly obvious. But remember, blood loss isn't always obvious. You can internally bleed, say in a ruptured AAA, abdominal aortic aneurysm. And how does this manifest? Well, in too much fluid, we talked about, remember, pulmonary edema, JVP, fluid on the peripheries, edema. In this case, what we usually see is a response, a physiological response to try and maintain homeostasis. So there's not a lot of volume in the blood, so the body doesn't warm the peripheries anymore, so the hands become very cold. The capillary refill, which is simply a measure of the amount of time that it takes when you press down and the skin changes colour, for the blood to return and give the skin its normal colour, becomes prolonged because there's not as much fluid about to perform that filling action. You get a tachycardia. The heart goes very fast because it still needs to deliver oxygen to the tissues, but there's just not enough blood, so it has to pump that blood that's there extra fast. A tachypnea, fast breathing rate. A reduced blood pressure, makes sense, a lot of fluid, reduced blood pressure. A reduced JVP, makes sense, high JVP with too much, low JVP with too little. And then these ones, sunken eyes, dry mouth, reduced urine output, again important. So those are the two sort of broad clinical pictures that you need to have in your mind. Okay? And whenever you approach there's a good reason I'm telling you this, because whenever you approach a problem about electrolytes or fluids, you must ask yourself that question. Is this patient got too much fluid, or have they got too little fluid? Because that's going to completely determine what your management is going to be. Okay? In one situation, you need to give them a drug, which, if you're wrong, will kill them. So if they're in the other situation, you could kill them. So say, for example, someone's got too much fluid, and you think that they've got too little, you give them more fluid, that you're going to make them worse. Conversely, they've got too little fluid, and you give them, say, frusemide as a diuretic, they're going to get worse. So it absolutely depends upon the fluid status. When it comes to treating with fluids, we have two different sets to use. We have crystalloids and we have colloids. Crystalloids are things that you'll be familiar with, things like normal saline, dextrose saline, 5% dextrose, and beloved of anaesthetists, Hartmann's. Colloids, on the other hand, are things such as blood is a colloid, such as albumin, and synthetic things such as you may have heard of gelafusin. Now, the difference is crystalloids are simply electrolytes within water. So in the case of normal saline, you've got lots of sodium in water. In the case of 5% dextrose, you've got dextrose, sugar, in water. Hartmann's complicated, you've got lots of things in there. In colloids, what you have is you've got fluids with a high molecular weight, okay, and water. So what that does is if you inject it into a vein, it stays within the plasma. It stays within that intravascular space. So for example, you're at the scene of a car crash and someone's bleeding out through their femoral artery and you've got a big line in, okay? You're going to want to put this in rather than this because it will stay better within the plasma. Okay. General rule, there will be people here probably going, I've heard different to that. But as a general rule, that's what makes sense. Colloids stay in the blood longer. And this illustrates that and adds another point. So colloids, big molecular weight straight into the blood, it's going to stay there. It's going to stay there. If you give 0.9% saline, what you're doing is you're adding fluid to these two spaces, the plasma and the interstitial. Initially, of course, everything will eventually, because of homeostasis, even out nicely. And if you give 5% dextrose, you are giving fluid to all the compartments, essentially. Okay. This is the absolute basis. This is the slide that I've been leading up to. This is the absolute basis of any fluid replacement therapy. Anyone on the wards, anyone who needs fluids, this is what you do. So first of all, you resuscitate the patient. So your patient is on the floor, they're bleeding out of their femoral artery, having been run over by a motorcycle or whatever, and you resuscitate. You give, I would resuscitate with respect to the airway, breathing, and circulation. I would give them colloid, or I would give them blood, all of which are natural colloids, because that stays in the plasma and maintains their perfusion. Okay, that person is then stabilized. They go to hospital, they have their femoral artery clamped, repaired, whatever the surgeons do, but they're still on the ward and they're not eating and drinking yet. Okay, so those people, obviously, they still need their 3 liters of water a day. They still need their sodium and they still need their potassium. They need their 100 millimoles of sodium, they need their 60 millimoles of potassium. And this is the standard regime. 1 bag of normal saline, 2 bags of 5% dextrose. 1 salt, 2 sweet, if you want to remember it that way, with 20 millimoles of potassium to each bag. Now that makes sense because the requirement is 60. So 3 times 2, 6. And then of course, say for some reason that person who'd fallen off their motorbike was in the hospital, invariably they got C. diff and started having diarrhea, you need to replace any loss from there as well. So fluid balance is important. Principles applicable to lots of areas of medicine, the effusion, ascites with Starling Forces. Understand how basic fluid and salt is controlled, extra-renal systems. Recognize the clusters of symptoms that say to you, this patient has too much fluid, this patient has too little fluid. Know common causes of these, which are basically obvious. You just kind of think, why would they have too much fluid? Why would they not have enough fluid? And know how to replace that in a logical fashion. Okay, so that's water. That's water. Now, sodium. As I said, a normal sodium is between 135 and 145 millimoles per litre. Remember that forever from this day. That's not going to change. That's going to be the case. Therefore, a low sodium is a sodium less than 135. Obvious. Beware. Some of you who have done clinical skills will know that you must not take blood from an arm that has had a cannula in it with a bag of saline or anything running into it. And the reason is obviously you increase the volume of the solvent, and there might be sodium in the bag as well, so you actually get a false reading. That's when that happens, we call it artifactual hyponatremia. The other situation is if the person has very, very elevated protein or lipids, they can sometimes get this thing called pseudo-hyponatremia, but that's just icing on the cake, really. It's not so important. What are the clinical features of a low sodium? Well, only remember 2 things from this slide. One is that they are very, very difficult to sort of guess. You wouldn't go, your first instinct if you see someone who's 40 years old and got nausea and vomiting and it's a bit sort of unwell, you're not going to go, oh, yeah, you've got a low sodium, mate. It's not obvious, okay, without actually doing the blood test. But there is a spectrum, okay? So at the very top end, people are fine, of course, because it's normal, or nearly normal. But at the very, very low end, a low sodium puts you in a coma, okay, and can give you very bad seizures. Those are the 2 things that you need to. And the space in between, well, there aren't really many symptoms that you could definitely say, this is a low sodium. So, why did I tell you all about fluids and go on about it? Well, one, it's useful, but also to understand sodium, you have to understand how to assess someone's hydration state. You cannot say what the cause or treatment of a low sodium is without knowing the hydration state of the patient. The other thing you must know is the urinary sodium as well. And for that, remember one figure, just remember 20. Urinary sodium 20 urinary sodium, remember that. So, someone comes along, they have a low sodium. Your next question is, well, why? Why have they got a low sodium? The way you approach this is you decide what is that patient's volume status. Have they not got enough fluid? Are they hypovolemic? Do they have all those things I spoke about? Remember the tachycardia, hypotension, cool peripheries, reduced capillary refill time? Do they have that? Or do they have hypervolemia? Are they short of breath because they've got pulmonary edema? Have they got pitting edema? Have they got a raised JVP? Or are they normal? Let's start with normal, okay? If they haven't got any disturbance in volume, most likely they have this thing called the syndrome of inappropriate ADH secretion, okay? And what's happening there is, for some reason, they are producing too much ADH, and therefore they are losing large amounts of sodium. Okay. Lots and lots of causes of SIADH. Most commonly, it's seen as a neoplastic syndrome or paraneoplastic syndrome because they've got a tumour on board, usually a lung tumour. But it can also be seen with hypothyroidism and various drugs. But oh, very good. I've forgotten the drugs, and here they are. So malignancy, any lung pathology, CNS pathology, and drugs. So if you want a bit of pharmacology there, your carbamazepine and chlorpropamide both cause SIADH. But the main one, malignancy, SIADH. Okay. And these are the actual diagnostic criteria if you look them up. A low sodium, well, obviously we're dealing with hyponatremia. A euvolemia, yes, because they're not hypo or hypervolemic. And as well, what they also have is an elevated urinary sodium and reduced osmolality, and that's because of the ADH, the inappropriate ADH that's being produced. Okay, so normovolemia, low sodium, think SIADH. If the patient has a low blood volume, as expected by all the things I spoke about, this is where the renal bit is important, that urinary sodium. This is where you need to measure the urinary sodium to know where the sodium is being lost. If the urinary sodium is greater than 20, okay, think kidneys. Okay, it could be, for example, a nephrotic syndrome. If the urinary sodium is less than 20, okay, then that implies that in the situation of hypovolemia, the kidneys are doing their job. Kidneys should not be sort of spurting out sodium when there's a situation where there's not enough fluid in the body. They should be retaining it to try and keep the fluid in. And that implies that there is loss outside the kidneys. So for example, a patient could have diarrhea or vomiting, or they could have been run over by a truck and be bleeding out of the femoral artery. Okay, and then this just illustrates some examples. Okay, so high sodium with hypovolemia, it's coming from the kidneys. Why is it coming from the kidneys? It shouldn't be. Something must be wrong with the kidneys. So either we're giving them diuretics, for some reason they've got an osmotic diuresis, so they can't keep the sodium in. Maybe they've got type 1 diabetes, a polyuric polydipsic. Mineralocorticoid deficiency. Okay, remember, mineralocorticoid deficiency, we're thinking Addison's disease. Addison's disease is hyponatremia and hypercalemia. Salt wasting nephropathy, which is the same. And then outside the kidneys, well, yes, vomiting, diarrhea, third space losses, which the two important examples are small bowel obstruction. Yeah. Okay, so hypervolemia. Right. So the patient now has too much water on board. Once again, you go to the urinary sodium, the key figure for which is 20. The urinary sodium is greater than 20, renal loss, urinary sodium less than 20, extra-renal loss. i.e., if it's greater than 20, the kidneys aren't working properly. They're losing a lot of sodium, but the patient's still hypovolemic. How could that be happening? Well, the situation that happens in is in either acute or chronic renal failure. And then if the sodium is less than 20, then we start thinking about other conditions to do with hypervolemia, such as cirrhosis, ascites that cause, for example, hypoalbuminemia, increased amount of water being in the intravascular space because of the protein pressure, and congestive cardiac failure, where there is a general drive to increase the intravascular volume to maintain perfusion because the heart isn't pumping correctly. Okay. Now, this is why it's important to know the volume status of the patient, because you can see if you just went in and said the treatment for hyponatremia is fluid restriction and diuretics, and the patient was hypovolemic, you'd be giving them fluids rather than trying to make them pee the fluids. So it's this shows it's completely vital that you know the fluid status of your patient. And it's obvious then. Hypovolemic hyponatremia, correct the hypovolemia. Hypervolemic hyponatremia, correct the hypervolemia. Euvolemic, you do a fluid restriction with basically the aim of combating that SIADH to prevent the sodium getting any lower and the patient going into a coma. And then if things get very, very severe, you can do all this stuff, this drug, dimethylocycline as well, but that's not important. Hyponatremia. Hyponatremia is very, very easy and is not as common as hyponatremia. Hyponatremia basically occurs with insufficient fluid intake, usually because the person actually hasn't got access to fluids. The body is very good at creating thirst in the context of a high sodium level. So most people, unless they're physically unable to, will go and seek fluids. Okay, but that may not be the case for, say, a little old lady who has fallen over, having breaking a hip as she falls and is unable to mobilize to get water, for example. So water loss increased relative to sodium loss is the other situation it happens, and that is with mainly with this diabetes insipidus, which we spoke about earlier. Okay, and as I said, hyponatremia causes increased osmolality, which leads to thirst, and therefore will only really happen if the access to water is limited and sensation of thirst is impaired. But fluid status isn't as important in this situation. And importantly, all you do is replace. Now, with all of these things, whether it be sodium, potassium, or calcium, you must replace electrolytes slowly. If you replace any electrolytes quickly, you basically you don't allow, or you create little deviations of homeostasis, and creating sudden gradients across membranes is not a good thing, because if you get sudden surges of electrolytes occurring within cells, particularly excitable cells, you can get neurological problems, you can get cardiac problems, particularly arrhythmias, and generally is not good. So generally, as a principle, anything to do with electrolytes has to happen fairly slowly. Okay, that's sodium. Potassium. Potassium's fun. Potassium's easy. Potassium 3.5 to 5. That's one of the figures. The figures were sodium 135 to 145. Potassium 3.5 to 5. The urinary sodium, I want you to remember, is 20. We need 3 liters of water per day. 100 of sodium, 60 of potassium. Okay. I like to repeat things. Sorry if I drone on about it, but more repetition the better. With potassium, if you remember, potassium was our main intracellular cation, or positively charged molecule. And as such, it's very important for excitable cells, such as the myocardium, which relies on it for normal conduction. and neurons, which to some extent do the same. Importantly, with potassium, you need to equate potassium with kidneys, okay? Because the glomerular filtration, or the normal kidney function, is the thing that allows you to adequately maintain and, most importantly, remove potassium. So, well, what are you talking about here? Oh, we're talking about hypokalemia. Okay. So once again, potassium, same as everything else, too much, too little. Okay. Causes of a hypokalemia: reduced intake, rare. Cellular uptake, do not worry about this. Increased loss is very, very common. Okay. So the situations where you might lose it is from the gut. There's lots of potassium in the gut, particularly in a situation of diarrhea and vomiting. Okay. So all your patients who come in with diarrhea and vomiting, if they're unwell, need to have their potassium checked to make sure they haven't lost lots of potassium. And then the other things we've spoken about before, really, if you remember, hypokalemia and hypernatremia with Cushing syndrome and mineralocorticoid excess. And these ones are not important. What does it do? Well, hypokalemia actually doesn't do very much. It doesn't cause very much harm. If it gets very low, it can do, but it's important to the heart. So what you can get is a little extra beat, a few cardiac abnormalities. And it's important for nerves as well, so a bit of muscle weakness. But it's fairly non-specific. The treatment is the cause. Eat more bananas, tomatoes, that kind of thing. And you can replace potassium as well, but it has to be done slowly. Remember, electrolytes have to replace slowly. Gosh, that shouldn't be there. Okay. What we're talking about now, I don't know why the slides are in that order, is hyperkalemia. This is important. Okay? Hyponatremia, hyperkalemia, and hypercalcaemia are the three absolutely key electrolyte things that you see every day on the wards in clinical practice all the time. So this is really important. Causes of an increased potassium. I think you'd have to eat quite a few bananas to get an increased potassium to this sort of level, above 5, but it can happen. Cellular loss. As I said, potassium is inside cells. So if you get massive hemolysis, so if all your red cells burst open because of an immune attack, because of disseminated intravascular coagulation or whatever, lots of potassium will leak out of them and will cause problems. Likewise, if you get a crush injury, or if our little old lady who'd been lying on the floor for 4 hours having fallen and broken her hip and unable to move, she might have a hypernatremia, not being able to get water, but she may also have a hyperkalemia because all the muscles have been crushed and the potassium leaked out. Most importantly, though, a high potassium is associated with renal failure. If you take one thing away from my thing on potassium, it's high potassium renal failure. The GFR is needed to get rid of potassium. If you don't have a good GFR, i.e. because you have renal failure, then you will get an increased potassium. And as we'll go on to see, an increased potassium is dangerous. But then as well, decreased mineralocorticoids, Addison's disease. Remember, hyperkalemia, hyponatremia. Okay, and what does it do? Well, it's fairly asymptomatic, which is a worry because it kills. If you have your potassium up at 6.5, 7, you're at a very high risk of going into ventricular fibrillation and dying if no one's about. Okay, so this one is really, really kills. And it does lots of things to the ECG, but for the purposes of intermediate MB, for the purposes of finals, you just need to know that it causes big T waves, like this. Tall, tented T waves. And this is the other thing that you have to know. And I guarantee you that at least one person in this room will see it on their first day as a house officer. You're called up, patient has a potassium of 7. Oh my God. You go and you have to do something because they could get VF and they could die. So what do? You first of all prevent them from dying in that moment. So what you do is you give them a drug that settles down the heart and makes it less responsive to the potassium. And that's called calcium gluconate. Don't worry, 10 mil, 10%, forget that. Just You stabilize the myocardium with calcium gluconate. You then push the potassium into the cells, get it out of the blood, because if it's not in the blood, it's not perfusing the myocardium to the same extent. It's distributed around the whole body. And if you remember back to your basic physiology, with insulin, insulin doesn't only push glucose into cells, it also pushes potassium in as well. So you give them insulin. That takes the potassium from the outside to the inside of the cell, and you don't want to give them a massive hypo, so of course you have to give them some dextrose as well. Those of you who are very, very keen will also know that beta receptors, if you stimulate them, also have effects with calcium. So you can actually give someone a beta agonist, such as salbutamol. And then finally what you can do is try and mop up the excess potassium using binding resins, such as calcium resonium, which is a sort of calcium thing you give orally that tastes like chalk, and it just sort of, it's like a big sponge, and it takes all the potassium away from out of the blood. And then finally, you may have to give them dialysis. But that's the principle. Stabilize the myocardium, get the potassium outside of the blood. Okay, potassium disorders are common and easy. Remember causes as altered intake, cellular redistribution because of crush injuries, etc., and altered loss, most importantly. So in hypokalemia, you're thinking altered loss in terms of diarrhea, vomiting, that kind of thing. And in hypercalcaemia, you're thinking about the kidneys aren't working. And then always in the back of your mind, if I see a high potassium or low potassium, what's the sodium? Because this might be an endocrine disorder, such as Addison's, Cushing's, etc. We're nearly at the end. So the final one is calcium. Calcium, although I didn't mention it before, is mainly intracellular. Not the way to make a quiet exit. So your calcium is your major, at least they closed it, is your major intracellular. A range, it's not so important. If you wanted to be keen, you're looking at 2.2 to 2.6, with a 3.5 level being very, very bad news. The important thing about calcium is that it's 50-50 bound in the blood to albumin. So any change in albumin actually leads to a change in the available calcium within the blood. And for that reason, the serum calcium, as the lab reports it, has to be changed according to the albumin. Now, I put some figures here, but essentially what most labs do, and in your exam, I don't think they'll expect you to calculate this, but they will say the corrected calcium is this. But just know that calcium, albumin are important, the ratios between the two. Okay. Calcium metabolism is a bit of a mind bend, but as far as I understand it, there are three key players in determining the distributions. You've got your parathyroid hormone from the parathyroids, those four small glands lying on the posterior aspect of the thyroid, and those react to hypocalcaemia. And what they then do is they lead to increased resorption of calcium from the bones and reduced renal excretion to the kidneys. You've then got calcitriol, which is produced by the kidney in response to PTH stimulation. So parathyroid hormone doesn't have a direct effect on the gut. What it does is it causes the 2,5-hydroxylation to 1,2,5-dihydroxycholecalciferol or active calcitriol, and then calcitriol goes off and allows the calcium to be reabsorbed from the gut. So remember that. PTH doesn't have its effect directly on the gut, but does it via this kidney mechanism. And then finally, you've got your antagonist to PCH, which is calcitonin. So what about the disorders? So let's start with hypocalcaemia. Now, if you have a basic schema like this just summarizes exactly what I just spoke about. So you've got your parathyroids, You've got PTH. PTH has an action on the bone, causing osteoclasts to release calcium, has an action on the kidney, preventing calcium loss, and it also causes this alpha hydroxylation to calcitriol, which then allows the gut to reabsorb more calcium. And you can have a failure in any one of these mechanisms. Okay, so first off, you may not have any parathyroids because you've had a thyroidectomy, or because you've perhaps had a thyroid tumor that's required radioactive therapy. So obviously in that situation, you've got no parathyroids, you're not producing any PTH. You might have a problem with your kidneys. Okay, so your kidneys might not be responsive to PTH, and in fact there are some syndromes, some genetic syndromes that make your kidneys non-responsive to PTH and cause chronic hypocalcemia. And then you may also not have enough unactivated vitamin D to activate. You could have, say, a vitamin D deficiency, something that's becoming more and more common in the UK. So, as I said, start at that point, think what can go through, then look at your textbook and see what the answer is. So, definition, it's low, so it's less than 2.2. Common causes, the most common is parathyroid removal, but you can also get it with renal disease and vitamin D deficiency. Diagnosis is easy. What you do is you actually look at the serum PTH, and usually that tells you most of the story. Most of the time it will be undetectable or low because of parathyroid removal. Also think if their U&Es are abnormal, if their urea creatinine was sky high, they might have kidney disease, and that could be the other reason that it's not normal. Clinical features. Now this is somewhere where in your EMQs often there will be specific weird sort of signs that they'll talk about, but that point to hypocalcemia. Okay, and these are the ones to remember. Forget fits. Perioral paresthesia. If ever you see perioral paresthesia tingling around the lips, or are told about it, that is hypocalcemia. Trousseau's sign. Chvostek's sign. I'll explain what they are in a moment. It causes prolongation of the QT interval on the ECG. We're getting more advanced now, and chronic hypocalcemia can also cause cataracts. But these are the main ones: perioral paresthesia, Trousseau's sign, Chvostek's sign. This is Trousseau's sign. You inflate a blood pressure cuff above the systolic blood pressure, and as soon as that happens, the muscles in the arm go into spasm, like this. Chvostek's sign is when you tap on the division points of the facial nerve over the parotid, the face starts twitching violently. Okay? And all of this has to do with the important role that calcium plays in muscle and nerve physiology, basically. That's why this happens. But those are the important ones. Treatment is very, very easy, but often not accepted by patients because the tablets are horrible. You basically give calcium supplements. The only situation in which you can't do that is in kidney disease. You often have to give them, they've got chronically low levels of calcium, you need to give them an activated form of vitamin D3 to allow them to reabsorb, because they can't do that activation for themselves. So in that case, you give them alpha calcidol, which does the job. Okay, now, the final thing that you must know about, remember, the important electrolyte disorders are hyponatremia, hyperkalemia, hypercalcemia, is this one. Same diagram, same principles. Why might you have too much calcium? Well, you might have too much PTH, either because of primary or tertiary. You could have too much calcium because there's a problem within the bones. There's some sort of malignancy. The bones are being inappropriately resorbed. They're being broken down. You could have a high calcium because some diuretics don't let you pee out your calcium, particularly dendroflumethiazide is associated with that. Thiazide diuretics. And then vitamin D excess, although possible, you might imagine there aren't that many people probably taking overdoses of vitamin D, but it is possible. Okay? So just more pictures. This is to, once again, get the point home. Use pictures, because they're very good tools for revision. This one shows TB. upper lobe consolidation, gone focus. And this one shows bilateral hilar lymphadenopathy. What I didn't mention here is another very important cause of hypercalcemia is sarcoid, granulomatous disease, sarcoid. Okay, so we know the theory. Let's look at what it actually says in the books. Common causes are primary hyperparathyroidism. Now, I haven't covered thyroid in this endocrine thing, but underthyroid also becomes disorders of the parathyroid, and you can get little parathyroid adenomas. And this is what causes primary hyperparathyroidism. These little adenomas produce lots and lots of PTH, and that causes lots and lots of calcium. Malignancy. Malignancy does its work in a number of ways, not only through metastases, which I alluded to a moment ago, but also through producing a PTH-like protein. If you remember before when we spoke about ACTH and malignancy, remember I said ACTH is not actually produced by the tumour, it's a sort of paraprotein that has ACTH-like properties and stimulates the cortex to produce this stuff. The same with malignancies and PTH-related protein. It's exactly the same mechanism. And then rarer causes, so granulomatous disease. TB and sarcoid are important granulomatous diseases. And then you get your diuretics, vitamin D intoxication, and all this sort of stuff here. Now, the features, this is another favourite. Bones, stones, groans, and psychic moans is the way that you remember it. All over body pain. Hypercalcemia is a cause of all over body pain. And what it does is, it's a result of these little areas of resorption that occur. Because of all that osteoclastic activity that's going on, you get little areas of resorption in the bone called Brown's tumours. They look like on an X-ray, and the posh name for that is osteitis fibrosa cystica. You get stones, so you get kidney stones, but you also get a nephrogenic diabetes insipidus. For some reason, high levels of calcium desensitize the kidney to ADH, so it can be a cause of nephrogenic diabetes insipidus. You get groans, abdominal symptoms, pain, vomiting, constipation, and psychic moans, weakness, fatigue, confusion. So as you can see, even though we've got this nice system, actually most of these things don't really fit together. You know, if I saw someone with weakness, fatigue, vomiting, abdominal pain, who was thirsty, I just think they might have gastroenteritis or something. You know, it's not obvious, which is why, of course, a lot of the time we send off lots of blood tests when we see patients and A&E and things like that. But that's the characteristic set that you'll see. How do you treat it? Well, just like hyperkalemia, hypercalcemia is a medical emergency because of the effects that it has on the myocardium. You treat it by giving fluids to push out the calcium, and you give also a bisphosphonate, which stops that resorption. It slows down the resorption of bony material that's giving that increased amounts of calcium. And then obviously if it's anything else like TB, for example, well, you treat the TB with antibiotics. If it's sarcoid, you might give steroids, etc. Treat the cause. Okay, so we've spoken about that. So that's pretty much me done. A few sort of take-home messages. Normal physiology in endocrine disease is really, really important. I would recommend before you start looking at any system that you just go back and look at the normal homeostatic processes before you start looking at the diseases. Okay? And when you start looking at the diseases, look at them from the perspective of what's normal. Because if you understand normality, when you start talking about pathology, things become a lot easier. And what you'll find is the disease processes just sort of fit in. You're like, okay, that makes sense because that bit's not working, that bit compensates, and that's why the blood tests are like that, and that's why the symptoms are like that. The other thing is have a system. Please, please, you guys are going, some of you are going off, I know, to do clinical next year. Some of you are starting learning less sort of biomedical sciences and more clinical sciences in your second year. Please, please have a system for things. Don't just open the book and open your notepad and write epidemiology, 5% of people get this. And what you really need to do is have a system. So Investigations, use the same table every single time. Management, use the same table every single time. What you'll find is the more that you use the same system, the more confident you get in not actually needing to look at the book. You start thinking, okay, I don't know a lot about sarcoid, but what investigations might I do? I'm just going to sort of fit the things that I read in the book into my own system. Because then when you're on the ward or you're in your exam and someone says, so how would you investigate this? Instead of going, oh my God, I can't remember the 10 investigations, you go, well, there is urine I could do bloods, I could do this, and stuff starts just to make sense. And the same for management as well. Okay? And importantly, for electrolytes, you need an approach. Now, all of this stuff, if you want to re-listen to this, it's on the website. It's free. You don't have to pay. It's all free on the website. And thank you very much for listening.